The House Appropriations Subcommittee held several hearings Thursday on the President's budget. Next, a hearing on the Center for Disease Control's 2004 budget. Smallpox vaccination and Asian pneumonia were just some of the diseases discussed. Ohio Representative Ralph Regula chaired the hearing. It's about 2 hours, 15 minutes.
Okay, we have a very important guest today, and want to get the hearing started. But I've asked my colleague from Georgia to introduce our guest today, Congressman Linder.
Thank you, Mr. Chairman. In 1993 to 96, I represented the CDC in my district, and my first visit to the CDC stunned me. You had, as I've said many times, a world-class intellectual community working out of third-world buildings, which should have been shut down, and if they were in the private sector, would have been shut down. Over the years, a plan has been drawn to repair it and fix it, make it more secure. You have been generous in this committee in providing that funding to fix it. It has few years left to go to complete it, but we have some of the best leadership we've ever had at the CDC. Dr. Julie Gerberding is providing stable and steady and competent intellectual leadership to a great community, and I'm pleased that she's here today. Thanks, Julie.
Well, thanks, John, and I have to say that she received her MD in Ohio, Case Western Reserve, and so I'm happy you appreciate that. Well, thanks for stopping by. You're welcome to stay if you'd like.
I just want to stop by and say hello.
Yeah.
Thank you.
Yeah. Well, we're pleased to have Dr. Gerberding here today, and we all look forward to your testimony. You have some great challenges on CDC. I think in terms of the public, CDC is kind of a well-kept secret. Most people don't know what you do. They don't realize it's changing, but historically didn't realize how important CDC is. I tell them back home, it's the watchdog agency over their health, and this is the agency that directly is responsible, and SARS is a good example, for things that are going to impact possibly on my constituents. I remember we had a meningitis scare 2 or 3 years ago, and we didn't have the war rooms then like you have, and the Secretary Thompson has to follow through on this, and there was a degree of unsettlement. Things were unsettled until CDC got on the scene, which was maybe a day or so late. But once CDC's team was there, everybody suddenly got more comfortable, the parents and so on. And it is an extremely important agency, and particularly in this day and age when bioterrorism is something on the minds of all of us, and probably one of the great terrorist threats. So we're happy to welcome you here. Steny, you're the senior minority. Would you like to say anything?
I think Mr. Obie is on his way. I saw him in the hallway, and I think he'll be coming here. But I want to join you in welcoming Dr. Gerberding to our hearing. Congratulate her on the work that she has done, and congratulate her on the leadership that she is bringing to this critically important agency. And I agree with the chairman. It is largely an unknown agency. NIH is obviously a very famous agency, but very frankly, in the context of today's world and our homeland security concerns, the CDC, in my opinion, will become one of those agencies that will be much more focused upon by our citizens.
Mm-hmm.
I want to say, Mr. Chairman, that investing in the CDC is investing in really saving dollars, because to the extent that CDC is successful, we will save billions of dollars in post-illness, post-trauma, whatever expenses. And so that the investment is really something which will give a very big payoff. You've heard me quote Ted Agnew before, the governor of our state. He was elected governor, and I was elected to the state senate the same year, and he gave a speech, his inaugural address on the steps of the Capitol in Maryland, in which he said the cost of failure far exceeds the price. The cost of failure far exceeds the price of progress, and that is true. If we invest in prevention, we will save the costs of the failure to do so. And that's what Dr. Gerberding and, as our colleague Mr. Linder pointed out, the extraordinarily talented people who work at CDC. And Mr. Chairman, as you know, I fight very hard for our federal employee raises. Mm-hmm. But if 95% of the people working at CDC were working in the private sector, they would all be making 10, 20, 30. In Dr. Gerberding's case, I think it's probably not a calculable figure, maybe 100%, 200% difference. But on average, I'm not at the top, we're obviously further behind, but on average, 10, 20, 30% behind. And the fact that we hold these people is because it is an opportunity to work, of course, in a very large field, and the challenges are obviously enriching, and that kind of compensation is difficult to replicate in the private sector. Having said that, they need to pay their bills. The last thing I would say, Mr. Chairman, is as a leader, as a very senior leader on this committee, you hear me talk about on the Treasury Post Committee with respect to courthouses, but it applies to so many different capital expenditures that we don't make. It is easy, as all of us know, in the short term to defer both construction and maintenance. It's not a cost that bites you in the first 6 months or 12 months, and you can save that if you have it tight. But what Jack Linder was saying is absolutely correct. We had extraordinarily able 21st century people working in 19th century buildings, and that just doesn't work. It doesn't work in terms of facilitating the product, but it certainly doesn't work in facilitating Dr. Gerberding's ability to hold and recruit the very best scientists that we need to do this kind of work. So, Doctor, thank you for your leadership. Thank you for the work you do. And please convey to all the people that work for you and with you how proud we are of the extraordinary work that they do. They are the best in the world, and we appreciate it. Thank you, Mr. Chairman.
Thank you. And your point is certainly well taken, that prevention, I mean, it's a cliche, an ounce of prevention's worth a pound of cure, but it's absolutely right. And much of the testimony we heard yesterday from your sister agencies was emphasized the importance of prevention. So we look forward to your testimony. Your complete statement will be made a part of the record, but however you'd like to summarize we'll be pleased to have that presented.
Thank you very much, Chairman Regula. It's an honor to be here. I really appreciate the opportunity to speak before the subcommittee, and I thank you for your warm welcome. And I agree with you. The workforce at CDC really is the most incredible asset that we could ever hope for. Sitting next to me today is Mr. John Tibbs, who's the acting director of our financial management office at CDC, and Mr. Kerry Weems, who is the acting assistant secretary for budget, technology, and finance in the Department of Health and Human Services. So I appreciate their support here. And I also really enjoy being here and respect and appreciate all the members of the committee and all of the support that you've given us for the last several years as we try to accomplish our mission. What I thought I would do this morning is just give you an update on a couple of the things that are highlights for us at CDC right now, but also use those to illustrate how appreciative we are of the proposed 04 budget, the President's budget, and how we're going to use those resources to further our mission. I wanted to talk first about SARS. You mentioned the severe acute respiratory syndrome. Obviously, this is taking a lot of our time and attention at CDC right now. I have a graphic here that I think can just give you the broad picture that this now is a global epidemic, potentially a global pandemic if we don't get the spread of this respiratory illness under control. We're seeing it across Asia. As of yesterday, there were 1,400 cases. We now know that it is probably highly prevalent in China. We're just getting the first data points out of China to tell us that there is ongoing transmission there in at least one of the provinces and probably more widely. But we also have seen 51 cases here in the United States. Most of the cases here have involved travelers to that part of the world, but there have been examples of spread to healthcare workers and spread to family members in close settings. At CDC, our leading hypothesis from our scientific laboratories is that this is a coronavirus. A coronavirus is a common respiratory virus, but this is a new one. We've sequenced the gene, and we know that it is not like any that we've seen before. We see it in many of the patients, and they are responding to this virus immunologically, so there's strong evidence that it is the cause of the condition. We don't have a treatment, and so our measures right now are implementing isolation and other practices to prevent spread. And what we're concentrating on in the short term is making sure that any travelers coming in from this part of the world are advised to seek medical attention if they develop a fever or any respiratory illness. So far, we've issued those alerts to about 100,000 returning travelers from this part of the world. Today, we'll be extending that to travelers coming in from Singapore and probably China. So it's a major issue, and we're doing everything we can to get the information out and get the confirmation of the cause. But I think, and I'll be happy to take more questions about this later if you're interested, but I wanted to bring it up because I think it illustrates, first of all, the value of the investments that you've been making in CDC, and also the importance of the budget proposal that the President has made for it. On the next graphic, I have a picture of the proposed buildings and facilities at CDC. We have very much appreciation for the $114 million that the President has included in the 04 budget for continuation of our master plan. What you can see here are on the far right-hand side of the graph, the laboratory that we are currently working in part for this virus, but also on the left-hand side is where we will have our Emergency Operations Center for Bioterrorism Preparedness. In the foreground are the infrastructure facilities for water and fire and power that we so desperately need to secure our campus, and a number of other investments that will really ensure that we get those scientists and those investigators working in the kind of facilities that will allow us to recruit and retain them and support them when they do their good work.
Mr. Chairman,
Yes,
could I just interrupt?
certainly.
I know that our colleague must be very proud of the fact that we're talking about the Edward R. Roybal campus and how proud he is, I know, how proud he is, I know, of the fact that his daughter now serves on this committee and espouses and fights for the priorities that during his long term in the Congress of the United States he fought so effectively for. I thought it appropriate to make that observation when we look at the Edward R. Roybal campus. Excuse me for that interruption. Thank you.
That's
Thank you.
appropriate.
If I can just move on to one other, I think, very important asset that we're evolving at CDC, and this is something that we're calling the Public Health Information Network. I think we all recognize that communication has got to be the backbone of everything that we do, and we, like everybody else, have a lot of enterprises in electronic health capacity, but what we're doing and what we'll be able to do with the investment in the proposed 04 budget is consolidate all of these disparate systems of collecting information or alerting people about things into a common public health information network that is seamless from CDC to the various local health agencies and the medical community, but also to the Department of Health and Human Service, to the WHO, and to our international partners. So the Public Health Information Network really is the backbone that will allow us, I think, to do our work faster and better in real time. On the next graphic, I am reminding you of the importance of another very, very difficult global epidemic, one that we've been struggling with for more than 2 decades, and that is, of course, the global epidemic of HIV/AIDS. The President has made a remarkable commitment to scaling up the investments in prevention and treatment of HIV internationally as well as domestically. In 2004, CDC will have proposed $50 million to expand our maternal to child prevention programs in 14 countries in Africa and the Caribbean so that we can get testing of pregnant women and get antivirals to them in time to protect their children from acquiring this infection. This is a scaling up of a very successful program that we already have and making sure that we can do more for more people in more countries. On the next graphic, I have sort of the opposite end of the spectrum of CDC's work, and I think this really speaks to your issue of an ounce of prevention is worth a pound of cure. That has to do with the health problems that are most important for Americans today. On the left column here, I've listed the leading causes of death in this country, and you know that heart disease and cancer and stroke and other chronic conditions are what's on the death certificate as the cause of death. But on the right-hand side, I have what are the actual causes of death in this country, the things that really cause the conditions of the chronic diseases. And for us at CDC, these are the things that we need to change in order to prevent the chronic conditions. And what's remarkable to us over the last decade is that in that red square there under poor diet and lack of exercise, that's the increase in the importance of that risk factor over the past decade. And you can see that lack of exercise and obesity really are almost as important in our country as causes of chronic diseases as is tobacco. They're catching up with the tobacco problem. And on the next graphic, we have this in more epidemiologic terms, which is really a pattern of the obesity epidemic in the United States. On the left-hand column, you can just watch over a 10-year period of time the increasing number of states where more than 30% of people are obese. And on the right-hand side of the graphic, the tragic consequences of this, which is the epidemic of diabetes, which is rapidly following on the epidemic of obesity. Not only are we seeing this in adults, this epidemic of diabetes, but we're seeing that in some communities where we are diagnosing new onset diabetes, 50% of the new cases are in kids. This is a tragic problem in our youth, and it's extending now back even into the preteen age groups, where kids are not eating well and not getting any exercise. So the President has made a Healthier U.S. Initiative to promote good health, and the Secretary has made the steps to a healthier U.S. very high priorities for the Department, and certainly those are priorities for CDC. So we are absolutely thrilled with the proposed $125 million in the 2004 budget for chronic disease prevention. This is an unprecedented investment in chronic disease prevention, and it will allow us to initiate programs in communities that combat obesity, diabetes, and asthma, some of the areas where we have evidence-based strategies that work, but we haven't been able to scale up to get them implemented and really make a difference for our kids and our adults. So that in kind of a macroscopic picture are some of the highlights of what our priorities are for 2004 and how we will use investments from this committee and how we've used investments in the past to really accomplish our mission of safer, healthier people in all communities. But we really do thank you for everything you've done. I also want to thank you especially on behalf of your father, for the enormous contribution that the support for our buildings and facilities plan have made to CDC. We could not be prepared for terrorism if we didn't have these investments. In fact, that laboratory building that I pointed out is the laboratory building that housed the anthrax labs, and we didn't have it until about 3 weeks before the anthrax attacks occurred. And if we hadn't had that building, we wouldn't have been able to do what we did in terms of accommodating those strains. The last thing I wanted to mention is that I think you all have a pedometer in front of you. Secretary Thompson promised you a pedometer to help you get your 10,000 steps a day in, and I know Chairman Regula uses the pedometer himself, but I want to encourage all of you to count your steps and step up. Steps to a healthier U.S. Thank you.
Well, the Secretary is really promoting the health issues, and he personally gave me one yesterday, and I had to take the pledge. Where? We're going to go a little bit out of order here, and I'm going to call on Mrs. Ryball Allard first. So I think that's appropriate, and if you'd like to make some comments or questions.
Okay, and thank you, Doctor, for your kind words, and I'll relay them to my father. I also want to thank you for the time that you are taking you took this past Tuesday to speak to Diana Bionta, California's Secretary of Health Services, about some of the concerns that have arisen with regards to the smallpox vaccination program. I know that the issues raised by Dr. Bionta, cannot be solved overnight, but your personal attention to them is very much appreciated. And I also want to thank you for sending out Dr. Gil Chavez to California to work on bioterrorism and smallpox and other health issues. The one issue that I do want to emphasize is the safety needles. I know that you're working with the FDA to come up with a solution to California's law requiring the use of safety needles. And my concern is that if we don't have a solution, it will have an adverse effect on the program, and our ability to expand it to the next level. So again, I appreciate the attention that you are giving to that as well.
Thank you.
Public health, as we all know, is critical to the well-being of any community and to this nation. And my district, the biggest event that I have is a health fair, which I started when I was first elected to Congress. And we have a variety of participants and activities, everything from bike helmets to child seat availability to comprehensive health screening. And a constituent can walk in and get screened for diabetes, for dental conditions, asthma, eye problems, and other illnesses. And we try to have the county's HIV, AIDS, and STDs bus available also for screening, so that the participants can get a variety of services. So healthcare is one of the biggest challenges that my constituents face, and I know that that's true of other districts in this country. There is one issue that I have been interested in for some time, and I've been working on it with Congresswoman Joanne Emerson. And we were sponsors of the folic acid education component of the Children's Health Act of 2000 to educate all women of childbearing age to consume folic acid daily from vitamin supplements and from folate-rich foods in order to prevent serious birth defects of spina bifida and anencephaly, which are completely preventable through, proper nutrition, as you know. And I understand that you do have a public education campaign that's underway that's directed at Latinas. And could you elaborate a little bit on that program, as well as what education programs you have in general for women, and are you seeing any results as a result of that?
Thank you. We do have a very strong partnership with the March of Dimes and with other partners to focus on the importance of folate repletion as a means to prevent spinal bifida. And when the FDA put out its regulation about fortifying grain foods with folate, we've been very interested in monitoring the success of that in conjunction with the educational campaigns. And actually, the combination of the information campaigns and the regulatory participation of the Food and Drug Administration, we've been able to document about a 31% reduction in the incidence of spina bifida in newborns. So already we're seeing that this program is having an astonishing success. It hasn't eliminated the problem because there are probably other causes of those sorts of birth defects, but the important issue now is how do we make sure that message reaches broadly into all cultural groups and into communities with with all diet habits. And so the component of the outreach information campaign that I think you're talking about is one that is designed to specifically put messages in cultural context for people who are Spanish-speaking or whose diets may not encourage them to eat the foods that are fortified with folate in the first place. So the supplementation program really does need to be something that is accessed by all women in all communities.
Well, it raises a concern because my understanding is that the President's budget actually proposes a reduction in the birth defects and developmental disabilities account. So what effect is this going to have on this education campaign?
Now, there's been some confusion about what actually represents a programmatic reduction versus what is a budget line reduction. Because we have management savings that are distributed across all the programs at CDC, you may see that the dollar amount on a given line is reduced, but in fact we are not making any program reductions in any of these programs. We have to identify ways to do these programs more efficiently within CDC so that we can reduce the overhead, but we are definitely protecting all programs.
That's very good news. Thank you. For over 5 years, 8 centers for excellence, including one in California, have been collaborating on the National Birth Defect Prevention Study, which is the largest case control study of birth defects that has ever been conducted. The centers now have enough information to begin using this data for studies that will lead to finding the causes of the birth defects of 80%, of which are unknown. Will these propose cuts in funding for the National Center of Birth Defects and Developmental Disabilities affect this particular study?
Again, we are absolutely committed to preserving all program support at the existing funding level, and that the changes in the budget line really do represent the management efficiencies and some information technology efficiencies that we intend to achieve intramurally at CDC. So we are committed to sustaining this very important program.
Thank you.
Be sure and thank your father for all of us.
Oh,
I hope
thank
he's
you, Mr.
watching
Chairman.
C-SPAN this morning.
You know, I forgot to call and tell him.
Dr. Weld.
Thank you, Mr. Chairman. Dr. Gerberding, I want to commend you and your team of virologists and epidemiologists for the work that you've been doing on this SARS issue. I know there's still a lot of questions yet to be answered, but I think we're getting answers very, very quickly, and it's better enabling us at the public health level to respond to the challenge that we face. And the American people need to know that the investment that they've made in CDC over the years in a situation like this has the potential to possibly save thousands and thousands of lives. The nation was wrecked by a horrible influenza epidemic in 1918 that killed millions of people globally, and this is hopefully it's not going to be like that, but it certainly has the appearance that if it were left unchecked and unaddressed, and the work that our CDC has done has been very, very helpful, not only to us here in the United States, but as well really to the world community. And so my commendations to you and all of your employees that are working with you on this. I have a lot of technical questions about this, but some of those you and I have already covered. I wanted to get into a couple of other issues. One of them is Autism Research. Your budget about $4.3 billion. About a quarter of it's going to HIV, STD prevention, a very worthwhile initiative. We've got 1 million people suspected HIV positive in the United States. We've got 500,000 people affected by autism, but yet a very negligible amount. And looking at the budget, you know, it's been reported in the New England Journal. I think it's your own staff has reported this, that the incidence of autism is definitely up, and yet it looks like we're about $3.5 million short on continuing the surveillance, the epidemiologic research necessary to get a better understanding of what is causing this. And you know, the concern I have each year as we leave this uninvestigated, more and more thousands more kids potentially could get infected or come down with autism, and there's a huge public cost associated with that regarding their education and their care and in their later years. Are you willing to work with me and the committee to try to restore the funding on this so we can really try to get some answers to these questions in the years ahead?
Yeah, let me just tell you that before I became the director of CDC, I had absolutely no idea the scope of the autism problem in our country. I mean, the study we just did in Atlanta showed that about 3.5 per 1,000 children in the city are diagnosed with this condition every year. And I don't know how to interpret whether it's going up or going down, but it's a very, very important and unbelievably common problem. We are doing a lot at CDC, both within our agency, but also in conjunction with NIH in the working group that's going on throughout Health and Human Services to deal with this. We have about $11 million in the Centers of Excellence for Development Disabilities, and a number of those programs are also doing research that's relevant to autism. So while you might not see it as a specific component of the budget as highlighted as autism, there are other efforts underway that will help to address this. But I think it's a kind of public health research that is a priority at CDC, and I'm really pleased that with the development of our new center for birth defects and development disabilities that we can now kind of recruit and develop the critical mass of people to really focus in on this problem. So we will work on it.
Well, I'm looking forward to working with you on this challenge. I have another concern, and that is we're spending over $1 billion a year, or $900 million a year, on HIV prevention. The concern that I've had is that we don't really have good measures of the effectiveness of these programs, but yet we've been funding them year after year after year. In particular, I was very, very concerned. Data coming out of San Francisco, a doubling of the gonorrhea rate, a doubling of the syphilis rate, and a significant increase in the incidence of HIV infection in that city, where a significant proportion of the HIV prevention dollars are actually being spent or misspent, depending on your perspective on this issue. And I also have a lot of concern about maternal child transmission of HIV. I don't really feel like we're addressing that properly on a nationwide basis. Again, your own CDC has reported as many as 400 preventable cases of maternal child transmission of HIV. Are we going to make any policy changes in the years ahead regarding how we're spending this money and developing some measures to see if we are spending this money effectively?
The short answer is yes, we are going to make some changes. Let me take your second question first, the maternal to child transmission question, because fundamentally in this country, no child should be born to a mother who hasn't been tested for HIV. We now have a rapid test. We can use that test even if testing hasn't been done before birth. We need to know where the children at risk are because we can protect them with antiviral treatment. So we are issuing some guidance and some recommendations to our colleagues in the medical community and to our state and local health partners to really ensure that we do everything we can to get mothers tested, and if they refuse to be tested, that we get children tested at birth so that we can do what we need to do to protect them. In terms of the overall value of the HIV prevention investments that we've been making, when I have been part of the AIDS medical environment for 22 years, and I was there at the very beginning. I watched policies evolve, and I think for very good reasons policies evolved in particular directions because we were sort of learning as we went. But now this epidemic is, in this country at least, is 22 years old, and it really is time to ask the hard questions of are we still on the right track? Are these dollars truly having an impact on the target populations at risk? Are we getting our money's worth? And to me, that's about accountability. One important change has occurred in the last year that allows us to, I think, know what the problem is and whether we're making a difference, and that is that we now have all states except Georgia reporting HIV and which is incredibly important because then we know what the incidence is, and we can see if it's going up or going down. It's remarkable that 22 years into an epidemic, we can't tell you what the incidence is, where with SARS, we have the epidemic for a few weeks and we can tell you what the incidence is in most populations. But it's taken a long time to get the political support, the climate, the knowledge base, the testing capabilities, and a lot of other advances to allow this to happen. And I think now we will be able to look at a jurisdiction like San Francisco or a state like Ohio, and we can say, look, your HIV incidence is going up, it's going down. How does this state different from this state over here where we see improvements? What are the best public health practices in those communities? Are we really doing the right thing, and what are the things that seem to be associated with a true reduction? So that's really where we are trying to take our overall accountability piece, and I think that people in the community of affected people need to have a voice in this, but I'm hearing a lot of support. They want the money to be well spent to protect lives also.
Thank you, Mr. Chairman.
We'll hopefully have time for another round of questions because this is a very important subject. Mr. Hoyer.
Thank you very much, Doctor. I'm trying to do these quickly because there's never enough time. Your budget proposes that state and local health departments receive about $940 million. If you include the $500 million for HRSA, about $1.4 billion on the hospital preparedness side on HRSA. Figure that's similar to what we provided last year. These funds were intended to help states and upgrade their public health systems to meet post-911 expenses. I know every one of us has talked to our local health departments, and they feel somewhat besieged and overtaxed in terms of what is expected of them. Now, Secretary Thompson said that states had not spent their preparedness funds. However, the discussions we've had with the governors and the states indicate that they have, in fact, either spent or obligated most of those funds, and we are directing them, as I understand it, to spend about a fifth of those funds, 20% for the smallpox program. Here are my questions. How are states to conduct both of these ambitious goals, upgrading their infrastructure and capabilities, and at the same time undertaking the smallpox vaccination program that is obviously way behind the president's objective at this point in time?
I think those two goals you mentioned are really united under one word, and that's preparedness. Smallpox immunization, pre-event immunization, is a really critical part of our preparedness right now, given the circumstances that the world is in. But in addition, infrastructure is also a very important part of preparedness. And so the measure of success in all this, are we prepared for a terrorism or any kind of a terrorism event? And are we prepared to be able to deal with other public health threats and emergencies? So the measures of our success are going to be preparedness, and I think in that sense, the smallpox program and the infrastructure development are all part of the same preparedness capacity. And it is a challenge to states to have so many important priorities on their plate at the same time. We're doing everything we can to provide the kind of technical assistance. We're deploying people to assist with some of these activities. Secretary Thompson and the department are working very hard to try to integrate between HRSA and CDC and make that as seamless as possible. But we recognize that this is a stretch, and people are really being asked to step up to the plate in short order and work hard.
Doctor, I understand that answer, and I think the administration would be very pleased with that answer. In NIH, we said we want to double the budget in 5 years. We did, in fact, double the budget in 5 years, but we added $1.7 billion in additional responsibilities to NIH in that process in response to biochemical threats. So that, in effect, what we did was we doubled the budget, but we added $1.7 billion. Obviously, that $1.7 billion obligation to meet an immediate proximate threat undermines allocation of those resources to cancer, heart, blood, whatever. I'm concerned. I hear your answer, but that, yes, smallpox and infrastructure upgrades are both part of preparedness. But if we indicated last year and the year before that we were going to allocate funds for preparedness, thinking that was infrastructure, and now saying that a fifth of that is going to be smallpox, and drawing down funds that I understand are already obligated, I think we need to watch that very closely. You don't need to respond to that, unless you want to.
But yeah, I actually wanted to agree with you.
Oh, okay.
And to say that
You can respond fully.
No, we understand that when we put the guidance out for the original allocation, smallpox was not specifically included in the program. And one of the things that we're doing is allowing states to, first of all, making it clear that they can use their preparedness money for the smallpox program. But in addition, we're releasing the first 20% of next year's resources now, so that if they are caught in the situation where they feel they don't have enough resources to invest or obligate for the smallpox program, they can draw down from the next allocation and not have the program get interrupted because of that. So we are working to do everything we can to try to make sure they have the support they need.
Okay, thank you. I understand that certain chronic diseases, diabetes, obesity, asthma, at CDC will receive substantial increases. You spoke to that. But many others that the committee is focused on will receive less. You also, I think, spoke to that in response to Ms. Roybos-Allard's question. But this is a concern to me. Epilepsy and arthritis, for instance, receive no additional funds, as I understand it. As a committee, we've struggled to ensure that we avoid disease wars. That happens at NIH. It hasn't happened as much at CDC, but we mentioned autism. As you know, there are a lot of people who feel that autism is underfunded as it relates to other afflictions. Wouldn't you agree that we need to increase all of these important resources to all the chronic diseases, and are we trading off one against the other? For instance, I don't know whether these figures are correct, but cancer prevention cut by 14%, diabetes cut by 3%, arthritis, other chronic disease 7%, health promotion, again, an ounce of prevention, health promotion, and again with obesity. I was shocked by those figures going from 1990 to 2001 in terms of the colors on that map in just 11 years. An extraordinary denigration of health as a result of obesity. Health promotion is cut in half by 56%. You are obviously called upon to try to administer all these and respond as responsibly as possible. And I understood your response, management efficiencies, and do more with less. Do you really believe that we're going to be able to do more with those important priorities? And do you agree they're important priorities with the resources that we are making available?
Well, let me just say that I've tried to understand all of the chronic diseases of public health importance and their scope and magnitude. And I know, for example, that arthritis is the #1 cause of disability in this country. So it's a very, very common condition, and CDC is doing a lot in partnership with other people. But there are obviously going to be increasing issues with this as our population ages. We are all working in an environment of prioritization. And when we announced the steps to a healthier U.S. focusing on diabetes, obesity, and asthma, we do that with the optimism that this program will be an umbrella for adding additional program support to it in future years. We don't know that, but that would be our expectation, that if we start with this focus area in the first go-around, that as we develop action plans for cardiovascular disease or for arthritis or other conditions, that they too could be part of steps to healthier U.S. and the kinds of community programs that we're investing will deal with them. The point you made about categorical funding is one that I feel very passionate about, because so often it's the same people. The person doesn't shop for their arthritis care and then their diabetes care and then their epilepsy care. They are coming to the same point of contact, and we need to have coordinated prevention services for these people, and that's really part of the philosophy of the STEPS program that we're trying to engage in, that it's for the person, not for the category of health problem.
Doctor, my time is up, and I have a longer question. I've been very involved, and this committee has been very involved in immunization, particularly immunization of children. The richest nation on the face of the earth, one of the most technologically competent nations on the face of the earth, as you know, has children vaccination levels at about 75%. A quarter of our children are not. I have questions on that, Mr. Chairman. I'll submit them, but I'm concerned about some of the cuts that have occurred, and I'll look forward to your answers on that. My time is up, or I would give you an opportunity to respond.
Well, I'd just like to follow up before we go to the next member. That is, as I recall, as a young person in school, we had smallpox vaccination was kind of routine. Am I correct?
Correct.
And I don't recall where there was all these problems. Is it because we're proposing to vaccinate an elderly or older population that we're getting into heart and a lot of concomitant issues that I never heard of when we were vaccinating school children routinely? What's the difference?
Well, when we look back at the most recent childhood program that we have information in, which was in the 60s, there were some important side effects from vaccine, even in kids who were otherwise healthy. There would occasionally be spread of the vaccine virus throughout the body, and sometimes just generalized infection that could be fatal. There was an encephalitis, a brain inflammation that could occur. They were uncommon, but at that point in time, the risk of smallpox was so great that we had to tolerate the side effects from the vaccine.
But there were side effects.
There were side effects, but we were not seeing cardiovascular complications of the vaccine. We did immunize some older people because you had to have smallpox vaccine if you were going to travel to a part of the world that still had smallpox. So there was an experience with revaccination of older adults, but we didn't have the same intense evaluation for side effects that we have added to the current smallpox program. We are monitoring the people in this program in every way we can to pick up any evidence of a complication or a side effect. So we practically have them under a microscope. So it's not surprising that we would see a greater number of adverse events because we're looking so hard to find them. We don't know if these cardiovascular complications are related to the vaccine or not, but because we weren't sure, we did issue the warning that people with coronary artery disease should defer.
Mr. Peterson.
Good morning, Dr. Gerberding. I look forward to working with you. The committee went down and visited your place several years ago, and I was impressed with the information, data, and wealth of knowledge you have. But when I look at your charts here a few moments ago, and if we look at this one, it shows that most causes of death are from personal choices, or bad personal choices, or bad habits. Would you agree with that?
I think there is individual responsibility here. I also think there's the social environment in which we're dealing with health and health choices. For example, phys ed in school. If the school doesn't provide the physical education program and puts candy bars in the pop machine, it's hard to say that the kid is making a bad choice.
Well, I would agree there, but those are choices by school districts or by local leaders. It's still about choices of health. What's the game plan of CDC to change this? I mean, we seem to be at a time when we've doubled NIH. We certainly have put a lot of money towards helping make America become healthy. But while we've been doing that, we really have become a less healthy nation because of bad choices.
We need to, first of all, take that good science coming out of NIH and translate it into effective programs and decisions and health policies that work. We do have evidence to support certain kinds of interventions, and they generally fall into one of those two categories: things that try to encourage people individually to make better choices, to stop smoking, to improve their food choices, to exercise a little bit more. But also, we're working with communities, for example, putting in sidewalks or making it safe for people to go out at night so that they can exercise comfortably, or working with school health districts to implement physical education programs and get kids up and running. So there are specific interventions that we already know work, and I think part of the healthy, the STEPS program is to disseminate information about those things that we know can help and get them actually implemented in the broadest number of communities that we can.
Do you use the states, though, as your vehicle to get this done? Are the states your conduit?
Well, CDC has a tradition of working primarily with state and local health agencies, but increasingly we've moved way beyond that because the community is really the place where the rubber meets the road, so to speak, and it takes participation of the local community or the local school district in the planning process, especially if we want to deal with health disparities or cultural relevance of some of the programs that we're talking about. So we're going beyond the states and directly to individual people through our health communications campaigns and our internet and so forth.
Do you have some sort of a working relationship with the Surgeon General?
Yes, we do.
Where is he? I mean, most people don't know who he is, the new Surgeon General. I can't think of his name at the moment, and I apologize,
Dr. Carmona is the Surgeon General, and he has visited CDC, and at CDC he was very, very interested in collaborations that would try to utilize his office and his interest in prevention issues to sort of be the spokesperson or to get out there in specific communities at the local level.
Well, but see, I think, I may disagree with you just a little bit in your approach. There's too many communities in America for you as an agency or for he as a person. I mean, this has to become a media thing. I mean, people have to know who he is. You know, we all knew who C. Everett Koop was, but in my view, there's been a big drop-off in the effectiveness of that office since then. I mean, but C. Everett Koop, I was a policy, I chaired a health and welfare committee in Pennsylvania when C. Everett Koop was Surgeon General. He drove policy in our committee. I would hear him on panels. I would hear him on national television. I go back and challenge my staff people. We got to do something about this at the state level. He had an impact not only on people, but he had an impact on policymakers because he spoke out. We don't have anybody speaking out, I mean, in this country. And I've been amazed the last 20 years that I've been involved in health issues is because the general public seem to have less and less knowledge and understanding that most of whether they're healthy or not depends on them, not on somebody else. It's about choices of exercise or not to exercise, choices of, and I guess I don't think a federal agency can reach all the communities. I mean, there's just too many. There's got to be some pipeline. When I visited CDC, I asked the question, do you rate the states on how they deliver your information? And the answer was, well, that would be controversial. No, but it would be good controversial because, and I'm going to suggest to you that have you ever read Giuliani's book on leadership?
Yes.
Chapter 4?
I read the whole book.
All right, well, chapter 4 is his formula where he went after crime first and he brought in all the precincts and he had a tremendous database and he told them what the crime was in their precinct and he challenged them to fix it. And as the winners started coming to those monthly meetings and how they had dropped crime, then everybody copied and did things, and it was strictly competition between them. Then he went down into the social field and foster care and all the other areas where agencies were ineffective, and he again had a database. And I guess I would challenge CDC to take this wonderful data you have, publish it, rate the states, and challenge them to change their numbers. If you have 50 states competing, you will change the health in this country quickly. I don't think any federal agency could begin to compete with that kind of a competitive factor.
Oh, I come from a healthcare background, and we do exactly what you're talking about in the healthcare environment. We measure performance and outcomes for specific kinds of interventions or specific kinds of programs, and I think performance measurement is part of the President's management agenda. We actually are trying to define credible performance measures for all of our important programs at CDC, and I think when we have that kind of information, we'll be able to really use that information in some of the ways that you're suggesting. So measurement matters, and if you can't measure what you're doing, you don't know whether you need to improve it or whether you've been successful. I think there's a lot of value in that.
Yeah, his first investment was in data systems, and everybody said he couldn't do it. Everybody said you can't collect that data. He collected it. He spent the money, and I think it made the monumental difference of any governmental leader I've ever known in my time. And I guess I think that model could really be helpful because I think the crisis of this country is its health. I mean, the cost of health care in this country is going to break our economic system if we don't. And it's about being healthy. It's not about curing diseases. It should be about preventing them. And I look forward to working with you.
I mentioned earlier on the Public Health Information Network, that is one of the major backbones where we will be able to get this kind of measurement information in. So that's part of the reason why I mentioned it in my opening remarks, because I really do feel that not only do we need to be able to send alerts and information out to people, we need to be able to gather the intelligence that tells us that we are or not having an impact.
But I'd love to see you rate the states. And I'd love to see governors defend being 45th and 47th and 48th. If you did that, you would bring about massive change. Would you come under fire? Sure you would, but I'd defend you.
Okay. I'll hold you to it.
You have one defender. And I might say to you, Mr. Peterson, we'll explore the possibility of having the Surgeon General, because I think you have a very valid point. We rate them in education and a lot of other things on a competitive basis, and health is, as the charts tell us, extremely important. And of course, it's education as a component of that. I at some point want to learn more about what you do and that education role that CDC plays. But Mrs. DeLauro.
Thank you very, very much, Mr. Chairman, and welcome. As I mentioned to you when I ran into you at the elevator, I just happened to believe, that CDC is a treasure, and we need to work with you as closely as we can to have you be able to continue to do what you do and to be able to expand the opportunities to do what you do. You have the ability to identify some of these issues, and with your research and with your work to really truly prevent and illness and disease in this country, and for that we are all grateful. If I can, based on my comments of my colleague Mr. Hoyer, Mr. Peterson, I think it's interesting to note, and Connecticut happens to be one of the states that is the beneficiary of the programs to promote healthy eating and physical activity and to reduce obesity. And I think the issue of choice and what choice individuals make is a commentary. However, the fact of the matter is, and I just say this to you in terms of the resources, when we have a budget that would cut CDC's nutrition, physical activity, obesity account by 20%, $6.8 million. We cut the health promotion account by 56%, $20.9 million. And we cut the youth media campaign by 90%, some 46 million people. We know our youngsters are watching television. We want to try to use the media to engage them. So I think that you do what you can with the resources that you have, but we do have a responsibility at the federal level to do something here, in addition to which, not your department, but there's the elimination of the Physical Education for Progress program in the Department of Education. So that makes it all the more difficult if you don't have a physical education program at a school, within the school district, not because the school district decided not to do it, because there are no funds to do it, then these youngsters are going to be couch potatoes. They're not going to go out and do what they need to do. Further, in terms of good food, healthy food, one of the results of shortchanging schools in terms of education dollars is that many school districts, many schools are contracting with vendors, and they're putting in, and nothing wrong with M&Ms, I love them, all the candy in the machine, because you know what? The school district gets a proportion of those dollars so that they can carry out some of the programs that they have. Most recently, big article, I wish I had it with me, was that Coca-Cola, they're contracting, a school district contracting with Coca-Cola, going into the schools with vending machines because they get a percentage of the of those dollars because they can't make it. And we are continually putting more demands on the states, local government, without providing the resources to do anything about it. I'm not even asking you to comment about it. I'm going to work with you to try to restore dollars for these programs as hard as I can, because I just think we need to, it shouldn't be just 12 states that have the advantage of this program about healthy eating and so forth. We need to move on to make sure 50 states have the opportunity. Let me talk about your buildings, though, and your, if I can, buildings and facilities, because I, too, was at the CDC in Atlanta in April of 2001. Briefed on the 10-year master plan, construction projects taking place at Royal Complex, conditions of the older buildings, etc. You're making progress in this area in modernizing the laboratories on 3 of the campuses, and that's in large measure, I think, to the $266 million provided to CDC's building and facilities account last year. I do have concerns about the current budget. There is a proposed cut, as I understand it, of $152 million, or 57% from CDC's buildings and facilities account in the president's budget. My questions in this regard are: how does the cut affect your 10-year master plan? How does this affect your ability to respond to a bioterrorist attack? I would like to work with you to ensure that the 10-year plan is on track. Under the master plan, what was the projected funding level for fiscal year 2004? I also have a lab question, too.
Okay. The 10-year master plan is something that we've been very appreciative for the support this committee has given, and we've certainly made a lot of progress. I think we would probably say we're about half through it. In terms of the bioterrorism preparedness capacity and what have we accomplished so far, we will be completing a second large laboratory, the bioterrorism laboratory, in this year and next year, and that does contain the rapid response laboratory that will handle incoming specimens and be able to instantaneously, or at least in a few hours or minutes, be able to determine whether there's a threat agent present in the sample. So we do have the resources to finish that state-of-the-art facility, and that's very, very helpful to us. We have an operations center that we just are in the process of opening right now, a war room, as Chairman Regula referred to, that is an interim operations center put together over a 6-month period because we felt that it was an emergency. But that operations center does need to go into a permanent building that has the proper room and the proper security for handling it over the long run. And the $114 million in the President's appropriation does allow us to initiate that facility to make sure that we have that operations center in its final resting point where we can conduct business appropriately during any kind of a public health emergency. I think in terms of the difference between the sort of ballpark $250 million that I believe was used to strategize for the master plan.
That was for 2004 was?
My understanding is that that's the ballpark figure that's been used as the planning element each year of the plan. I would have to get back to you for the record to understand what will be the consequences of the proposed allocation. But I will say again that we are all prioritizing, and having this $114 million to focus on the operations center is a priority for me, and so I'm very glad that it's in the budget.
I'll come back with questions on security and wise woman in the next round. Thank you.
I think overall, I note that the increase about $40 million, and some of this is distorted by the fact that the 04 budget came out before 03 was put in place, and so the final numbers will probably reflect an increase, we would hope. Let's see, Mrs. Northup.
Thank you. I want to add to some of the previous comments about getting information from the laboratory to the marketplace in our communities. I think what you're doing about obesity, about healthy eating, exercise, is hugely important. In fact, I feel like there's a huge change in our approach. That for so long in this country, there has been sort of this sentiment out there of, why do we say people should be thin? Why, we should like it that everybody, sort of finds their own comfort center, and that's true. I mean, it's not a judgmental thing, but the fact is your health is directly related to your exercise, your activity level, and what you eat, and maintaining your weight. These are tough issues, and they're tough issues in every family. And the CDC leading the way to sort of jump over, I would bet that in many families there is this residual worry, as there was for years about smoking. Nobody wanted to tell Dad he shouldn't be smoking, but the truth is it was killing him. And so you really don't want the 8-year-old telling the dad he shouldn't be smoking, but the information coming and sort of permeating our understanding of health has made an enormous change. We need to do the same thing about weight. And I too feel that often CDC is so good about understanding these issues and how important they are, but has trouble making them commonplace understanding around the dinner table, in the community. It's maybe too many scientists and not enough public relations people, to simplify it. And I would just really encourage you to do far more to be the voice of reason that puts the old thinking to bed and the new thinking that it matters what you eat, it matters whether you gain weight, it matters whether you exercise, that you affect your health. And it's, in some ways it is related to personal responsibility. It's hard. Most of us like to eat more than we like to exercise, but it's important.
One of the things that we've been aware of, to just completely agree with what you said, is that scientists aren't always the best communicators, and we do have to have a translation capacity to take that knowledge and then disseminate it and distribute it in a way where it has meaning and value into people in the communities and in all kinds of communities. Part of the appropriation that we received in '03 is helping us build a communication center, which is this enormously beautiful physical facility that has our television studio, our library, the heart of our public health information network. But also, in order to make this building be worthwhile, we are building up our translation capacity. We're getting the communication capacity that we need. We learned in anthrax that we needed to have a stronger voice and to really help translate health information to people.
And not just through medical journals, not through public television interviews, serious, but really much more widespread to the as Ms. DeLauro talked about, our children that are getting information. They're not listening to the public television roundtable discussion about this, or mine aren't anyway. So anyway, I hope you will work on that. Let me just ask you one other question about it, and that is its relationship also to mental health, because I have believed for years that physical exercise, physical activity, and aggressive exercise is much a part of mental health as it is physical health. And yet I never feel that there's a whole lot of research or communication of that. I think whatever research there is does show that the endorphins help, but I just wondered if you all are doing anything in that area.
Again, that's a sort of a, how can we get from the bench to the individual, we say to the trench, but how can we get the information out in a way that makes sense? And part of that is we need to have that public health research so that we really do understand what is the relationship between exercise and mental health. Are we doing the right things? Are they making a difference? Are strategies for dissemination the most effective or the most cost-effective means of getting the word out? We do have the youth media campaign, which is the VERB campaign that I know you have been very supportive of on this committee, and our assessment so far is the campaign is successful. Most parents don't like it. Most tweens do. And we, out of the 11 million or so kids in that target age group, we've been able to get at least 3 million of them affected by the campaign. They're going to community events, they're participating in contests and sweepstakes that we're promoting, they're logging into the website, they're taking steps. And so that kind of direct marketing and communication campaign really can be a useful tool. We're evaluating this one very carefully because we think it will help inform what is working and what isn't working, and it may be a strategy we need to utilize more broadly. So appreciate your concept.
If I could just add one remark, and that is that there is nowhere this is more important probably than our smaller rural communities that tend to be the last ones to get information regarding personal health. And maybe I feel like in some ways this exercise and eating is very closely related to, if I can say, style, and so it catches on faster. And in strong metropolitan areas. But I don't think, it's like in style not to smoke. If you're in an urban area, I mean, many of the workplaces don't allow you to smoke. It's not considered okay. But that takes a long time to get to rural communities, and their health is affected by these things. So I ask you, when you're thinking about getting the word out, to think about rural communities.
Thank you. Thank you very much.
Mr. Weicker. Are you finished?
Yeah, I'm finished. Thank you.
Mr. Weicker.
Thank you very much, Mr. Chairman and Dr. Gerberding. It's wonderful to be here. I apologize for coming in during the latter stages, and I'm sorry that I missed your beginning testimony. I agree with the gentlelady from Connecticut that CDC is a treasure. I was one of the first several years back to encourage the previous chairman of this subcommittee to have a CODEL to Atlanta to see the CDC. I've been there twice, and what I see with the fiscal plant, proposals looks really, really good, and I wish you well. Let me just make sure I understand now. I was a bit confused by something that my friend from Connecticut said about cutting various chronic disease prevention and health programs, and I see here on Exhibit G1 that actually there are sort of small reductions in some of the individual programs, and then it looks to me like you're trying to wrap all of this together in this very generous new program called Steps to a Healthier U.S. Is that correct?
There are a couple of things that complicate the understanding of the dollar amounts, and I may have to get back to you for the record on some of this. But basically, because the budget that we're looking at was created before the 2003 appropriation passed, in some cases there are confusions in what's an increase or a decrease. But where we're actually seeing from our view of the budget at CDC on a line-by-line basis, where we're seeing reductions in line items, those are only management savings and IT savings. We are not cutting any programs. So it may appear that way, and we'd be happy to explain the difference. The healthier steps, the Steps to a Healthier U.S. Are a set of programs that provide an umbrella for targeting chronic disease prevention programs. And in the 2004 proposal, we're focusing on diabetes, obesity, and asthma. So they will be built on the existing obesity, diabetes, and asthma programs. They won't be replacing them. Does that answer your question?
It does, and I appreciate the fact that you're planning to get back to us on that. We'll be working together during the course of this appropriations process. But I do notice, though, and I would point out to my colleagues, that what we have on Exhibit G1, when you roll all chronic disease prevention and health promotion together, it does look like a substantial increase taken as a whole. Now, I want to get back to one part of your testimony, where on page 3 and 4 you point out that lifestyle choices that we make account for the vast majority of chronic diseases that we have in the United States. And it seems that should be an easy sell for CDC and for this committee, but if it were easy, we would have solved it a long time ago. You say 70% of, you say that the lifestyle type choices cause 70% of all deaths each year and account for 75% of the healthcare costs in the United States of America. It just seems to me that you're making the correct choice there to attack something that we can do as Americans. Let me just ask you, have you quantified in any way the amount of money the government would save in health care costs if the goals outlined in your budget could be attained?
When we calculated the lifestyle of the actual causes of death that contribute to chronic diseases in this country, and actually Dr. Frist asked us to redo this recently to try to see if there'd been any improvements over the last decade, and what we ended up showing was that in fact obesity and inactivity are contributing even more to chronic diseases in this country, not less, so we aren't going in the right direction for sure. We tried to put a dollar value on it, but it's very difficult to do that accurately on a macroscopic level, because obviously as we age, sooner or later we develop some health problem. And so trying to calculate what we would save in our healthcare delivery system is a little bit of a complicated calculation, but we have made some relatively crude estimates, and I would be happy to provide those to you.
Right,
for
a
your
range
interest.
or something like that. But it stands to reason that if we could reverse this trend, we'd not only be improving the quality of life of our citizens and ourselves, but also it would have an effect on the budget. Let me just briefly move to an alarming statistic that type 2 diabetes is now affecting more and more children. Do you think that's a direct result of the obesity problem that we have? And what more do we need to do, and what does CDC need to do to address this particular trend? Is it just a function of diabetes, or is there something else there that we're not seeing?
The increase in diabetes in kids is tracking very closely with the obesity epidemic in children, but CDC is working on a project called SEARCH, which is a public health research project to really look at a cohort of children and identify, is it in a prospective way, is it obesity leading to diabetes, or what other factors are contributing to the development of diabetes. So we'll have a scientific answer for that in addition to our general impression of watching one go up and watching the other one go up simultaneously, but it's certainly the leading hypothesis.
And I would just suggest also to my friend from Connecticut, I don't mean to pick on her, but maybe we could install juice machines at the schools and let the healthy food companies sell a few drinks and give the schools a take on that.
And you don't pick on me. Truly, it's okay. I have a lot of answers for what you've said, but it's a good debate. But I suspect that the schools would look for almost any opportunity to be able to achieve additional funding, given the kinds of cuts that we're doing, and particularly now with No Child Left Behind, which has severely been cut. I suspect that they're going to go out and look for additional ways in which they can make up the difference in the number of programs. But we ought to be encouraging juice. We ought not to be, and we ought to do that in our school lunch program as well, which, as we know, is going to be severely cut by the budget as well.
Mr. Chairman, ages and ages from now, the gentlelady from Connecticut or I will eventually get the last word in. Won't be today.
No, I'm going to get the last word in. Well, I think you've got a good point. I've noticed in the supermarkets now they feature juices of all kinds, carrot, fruit juices, not beyond orange juice, and some of the we know. And it would seem if I were superintendent, I'd at least like to have a machine in there that would offer those nutritious juices. But what I think
Isn't that a
you
crazy
both
way
lead to, and that is education. And I am a little concerned that the information technology program has a reduction, at least in the president's budget. Isn't a lot of what you're saying this morning predicated upon a high quality of information, not just quality, but volume of education? You do it with the youth program, but isn't there a real need for education on the importance of nutrition and the importance of things that affect health, as shown by your previous chart?
We really do need to have a very comprehensive communication strategy, and that is being built into the programs that we're talking about. For example, the Steps to a Healthier U.S. does include in it a communication strategy backbone for the whole success of the program. Just to clarify one issue, and Mr. Weems can correct me if I'm incomplete in my answer, but the IT savings that we're talking about in the budget are really for internal support, sort of our business systems at CDC, where we have 100 different software packages, and it's a management, not the external part, which is that public health information network that I talked about.
So public health would not be affected.
Yep.
And one other question, and I'll go to Mr. Kennedy, but there's adult diabetes and juvenile diabetes. Could we clarify the difference? Is just one lead to the other? Because there's been a lot of emphasis on diabetes by virtue of nutrition impacts and so on. And I think it'd be well if we could clarify the two different.
In the past, we did refer to adult diabetes, which is diabetes mainly associated with obesity, and juvenile diabetes, which tended to be a very different illness in young children. What we're seeing now is that those words are not the right words to use. We now call type 1 diabetes the kind of diabetes that's very severe and requires insulin very early on, and often those people are thin, and type 2 diabetes being associated with obesity and insulin resistance. And what's happening now is that children are getting the adult type diabetes. They're getting the sort of diabetes that's associated with obesity.
So they're moving, the impact is coming closer together in terms of definition.
Exactly. And in addition, children who are obese are not only developing diabetes at that age, but in addition, they have the other risk factors for coronary artery disease and cardiovascular complications at a much earlier age. So their lipids are abnormal. They have hypertension that we didn't used to see in children. They have all the health problems that we would see in an overweight, middle-aged adult, and they're just acquiring those issues at an earlier and earlier age. So it's a complicated and very, very serious health issue for our youth.
You touched on the SARS question earlier, and I had a call in the meantime to my office to give you the practical application from a couple that are going to want to travel to Hong Kong. And they said, would you ask the director what advice she would give to Americans traveling to Asia? And this, of course, is being broadcast, so I think it's an important piece of information.
Well, Chairman Regula, we work in collaboration with the WHO, the World Health Organization, which really is putting together the whole epidemic picture. Right now, as of this morning, we are not issuing any travel restrictions to any part of the world. But we in the U.S. are advising people that if you have elective travel to Hong Kong or Hanoi or Singapore in China, and you can defer it for a while without causing great inconvenience, that would be a good thing to do. So if you don't have to go there right now, maybe you would want to delay until such time that we have a little bit better understanding of how this is being spread there and what people can do to protect themselves. So there is no official travel restriction, and when people return from those areas, they will be given an alert that says if you get any kind of fever or illness in the next 7 days, you must see your physician and you must tell your clinician that you've been in that part of the
Be
world.
handed out where, at the airplane?
At the airport, just as you come in through ports of entry. We are giving them out to people coming in both on flights directly arriving Hong Kong to U.S. ports of call, but also flights that are indirect. If the flight has been in some other part of the world and passes through, or the passenger has passed through en route to the United States, we're covering those. And as of today, we're initiating that in passengers returning also from Singapore, because the epidemic seems to be growing there, and we will likely be able to initiate it in China. Actually, this is one area where the Surgeon General has been very helpful to us, because the Commission Corps, under the Surgeon General's direction, will be helping us deliver these travel alerts as we need more and more people and support for the program. So he's really stepped up to the plate for that.
I'll yield to Mr. Wicker.
Dr. Gerberding, have you found out at all whether people who've had flu shots are less susceptible to this type of virus?
We have not been able to study that particular question right now, but because our leading hypothesis is this is a coronavirus, very distinct from influenza virus, it would be unlikely that the flu shot would have any impact at all. When we are completed with investigations, we'll have a group of people who have had the illness and comparable people who haven't had the illness as a control group, and one of the things we'll be looking at is immunization and other details that might explain why some people have it and some people don't. But my best guess right now, it won't be related to flu vaccine.
Mr. Kennedy.
To follow up on that, obviously this is a growing epidemic, and I would ask you whether you have adequate resources given the increased demand on your time and energy and the resources of CDC to address all these new implications as a result of the epidemic.
One of the hallmarks of this particular response, and we are managing this through our emergency response center at CDC, but from day one when we activated the response center about a week and a half ago, we made it very clear that we wanted to be managing this with the rule of parsimony, meaning with the most right-sized operation that we could. Because right at the time that we activated the operations center to deal with SARS, we were also on orange alert because of the Middle East conflict, and we recognized that this puts us at increased risk of a domestic terrorism attack, and we don't want all of the CDC focusing on this problem because we need to be vigilant and alert for something else. And we put the same thing out to our state and local health partners.
Can I ask you, following up on that, given the crisis preparation that you're having in terms of a possible terrorist attack, what are you doing to address the behavioral issues of compliance in light of a terrorist attack? I would be sure that after we had the anthrax scare here, all of our hospitals got clogged because people thought they had anthrax. I imagine with SARS, once there's a case here in this country, anybody with any kind of flu or cold will think they might have it. And you're going to have all of our healthcare systems overrun with people with psychosomatic issues. And how you're dealing with that aspect, the behavioral mental health aspect of a biochemical or terrorist attack.
Thank you. You're raising, I think, the issue that will be the hallmark of whether we succeed or we fail, and that is communication. Are we able to give people the information they need when they need it? Because I think what Mayor Giuliani showed us is that if you have information, you can manage people even in times of great fear and stress if they trust you and you are a credible witness to what's going on. So we have put a great deal of the effort at the state level into improving the state and local public health communication capacity. Our health officials are getting risk communication training that we've provided comprehensive training in this respect. And at CDC, we have really scaled up our own public affairs efforts. Hopefully you've seen that we've been out in front of the SARS epidemic with press conferences and briefings and so forth, because we think that capacity builds trust and it will be absolutely critical to how people respond and the credibility of the advice that we would give in case of a terrorism threat. So we're building credibility, we're building trust, and we're building capacity and also competence within the system. But I agree with you that really will be the make or break component of our preparedness.
I would very much like to hear a more detailed approach as to what you're doing to build resiliency amongst the public. This country hasn't been accustomed to terrorism on our own shores, and I think one of the single leading, most complicating factors of a terrorist attack is obviously the psychological impact of a terrorist attack. Obviously, it's a psychological warfare in a sense, and I don't know if our country is adequately prepared so that we don't end up exacerbating an already bad situation by the way we respond. And I'm not so sure we have adequate response on the psychological and behavioral front.
I'd be happy to get back to you and follow through with that, because I agree that it's very important.
Mr. Chairman, we've heard from our Secretary Tommy Thompson about this, how he believes that the response plan, we spent a lot on bioterrorism and inoculations, but how do you inoculate everybody if in an event like this, and how do you run them through the decontamination? I mean, can you imagine setting up these tents, decontamination tents, and getting people to go through them? I mean, just to me, it'd be a logistical nightmare, let alone the panic that would ensue. So it seems to me this is an area that we need to focus on, and the Secretary clearly acknowledged that he had not achieved the plan that he'd like, and it's clear once again we have an issue here we need to focus on. I would thank you very much for your testimony. And I have a few follow-up that I'll put in the record in terms of asthma and diabetes and health promotion. Thank you.
Mr. Jackson.
Thank you, Mr. Chairman. I want to start by thanking Dr. Gerberding for being here today and for her testimony. And I apologize for being a little bit late. Dr. Chairman, I have 3 questions. In fiscal year 2003 conference report, the committees requested a comprehensive report detailing the implementation of the Minority AIDS Initiative. I'm eager to see this report as we go into fiscal year 2004. People of color continue to make up over 70% of the new HIV infections, and in 2001 made up more than 70% of AIDS cases diagnosed that year. Ms. Gerberding, how do we ensure that people of color get access to early treatment so that they don't progress to AIDS and stop being the majority of new AIDS cases?
One of the things that I think is going to help us finally is that we have this rapid HIV test. We don't have to have people come to a healthcare environment or a special testing clinic to understand that they have the disease. We can test them in their own communities in a variety of less traditional healthcare settings and really reach out and identify folks in the community context who might be at risk and get that test done. Of course, the testing has to be accompanied with the appropriate information and the referral to the established healthcare system if the person has a positive test. We are waiting to be able to implement the test waiver. I'm not sure if you're familiar with the regulatory language here, but the new rapid test that we have right now still can only be done in a certified laboratory, but it's been approved so that it could be done in a variety of other settings. There are just some process issues that have to happen before we're easily able to do that. The CDC is going to strongly recommend rapid testing in a variety of the settings that we support in an effort to reach out to communities that otherwise may not have the best access to traditional healthcare environments. So that's at least one step that we're going to be putting a great deal of priority on.
Thank you. Dr. Gerberding, as you know, pulmonary hypertension is a rare disorder of the lungs in which the pressure in the pulmonary artery rises above normal levels and may become life-threatening. For the past several years, the subcommittee has encouraged CDC to establish a pulmonary hypertension awareness program targeted at both the general public and healthcare providers. In fact, in fiscal year 03, Omnibus Appropriations Bill requested that the CDC provide a report to Congress by August of this year detailing the progress that has been made in this important area. Can you please tell us what actions the CDC has taken to initiate this much-needed program?
I do not know, and so I will find out and get back to you for the record.
I appreciate that. One last question, Mr. Chairman. The CDC and states should be congratulated for achieving 10 straight years of declining TB case rates in the U.S. There's been a dramatic turn about from the rising case rates we experienced in the 1980s and the 1990s after the CDC TB program was effectively dismantled. However, I am concerned that the overall trend of nationally declining case rates is obscuring the persistent problem of TB in the African American community. TB case rates among African Americans, especially in southeastern Atlantic states, remains high. I'm wondering, what is the CDC doing to address the persistent TB case rates in the U.S.-born African American population?
There are health disparities in TB in this country, both among native-born Americans as well as people who have emigrated here from other parts of the world. We do have a strong investment in the tuberculosis elimination program generically, and are funding local and state health agencies to do the kinds of follow-up and directly observed therapy and other interventions that we know are the way to successfully identify people at risk for TB reactivation and treat them with preventative therapy. In the past year or so, we've been able to identify that shorter course therapies can work, and so that's an advance that allows us practically and logistically to reach more people. We're also linking the tuberculosis programs in a more comprehensive way with the HIV programs at the community level, as well as STD programs and other services for people in urban or underserved areas in rural settings as well. So I think the comprehensive commitment is investing in populations where the health disparities are the most prominent, but we can still do more, and we need to keep pushing on this because we haven't completely eliminated those disparities yet.
Thank you, Dr. Gerberding. Mr. Chairman, thank you.
Mr. Lowey.
Thank you, Mr. Chairman, and Dr. Gerberding. I'm sorry I was delayed as well at a Homeland Security hearing, and I know the work you're doing is intimately connected to all we are planning for security in our hometown communities, and I thank you very much. I'd like to ask the first question about smallpox. I know it's been discussed somewhat. I realize that HHS recently announced that states and municipalities can use 20% of their CDC bioterrorism funds for this cause. But this is not enough. First of all, when the bioterrorism funding was initially appropriated, the smallpox program was not even on our radar screen. New York City and New York State, therefore, obligated their funds for other chemical, biological, and nuclear attack readiness activities. Even if New York City were to use 20% of its bioterrorism funding for smallpox preparedness, it would barely cover the bill. The cost of implementing just phase 1 of the smallpox program is $9.5 million. And by using the full 20% of the preparedness funding, the city would still fall $3 million short. More importantly, the state and city would have to abandon other important bioterrorism readiness projects. It is also worth noting that New York State just announced that it is stopping the smallpox vaccination program through at least next week because of the information that recently was released about heart disease and that people with heart disease should not receive the inoculation. The state may reprint educational material which will cost more money. First, can you please respond to concerns about the general costs of implementing the smallpox program? Secondly, can you also tell the committee a little more about how the CDC is addressing the heart disease concern? It is my understanding that many people with heart problems are even unaware of their condition. How should our healthcare clinics providing the smallpox inoculations respond?
Let me address the cost issue with a opening remark that I think is the most accurate thing I can say right now, and that is we've never done this before, and we really don't know how much it's going to cost to implement the program to protect the smallpox responders and the other first responders that are included in the President's program. But on the other hand, we have put out more than $1 billion into the public health system to help with terrorism preparedness, and that money was assigned to preparedness activities that includes planning around how to distribute materials to the population on rapid time, such as antibiotics or vaccines. That was one of the stated competencies that planning was to be directed at. It included investigation capacity. It included development of laboratory capacity. It included communication capacity, clinician education capacity development, IT development, and a lot of the other competencies and capacities which will directly provide a foundation for the specific case of smallpox. So we didn't include the smallpox program in the initial guidance, but we did include many of the foundations that would be necessary to make the smallpox program work. And certainly states can use their resources to support their smallpox program. That was a misunderstanding, I think, early on, that they couldn't use any of their preparedness money. We know that this is not free, and there are costs associated with doing this program. I think what's in dispute is exactly what those costs are and what can we do with the resources that we have, and what might be the additional costs that we're talking about. If you assume that we have made this investment and the states are able to develop these infrastructural capacities, our best estimate right now is that the actual inoculation cost is somewhere between $10 and $15. But we're going to watch this, and we'll know more as we go forward. Right now, the programs are still very small, and so there's great inefficiency. If you're only immunizing a few people here and there, the cost is large per person vaccinated. But as we scale up, we expect the costs there'll be some efficiency in volume, and we just have to get the information, and we'll be working with New York and with the other places that have the largest numbers of people to immunize to identify any gaps that exist.
I just want to mention that I just think it's important that we, as the kids would say, get real. We have seen the communities in Westchester County, which is my district, present proposals, and we're not anywhere near funding them. And as I've said over and over again to the President and others in the administration, we will support every dollar the President needs for the military. But I think protecting people on the home front is extremely important to all of us who have that responsibility together. And I think we should really have as accurate evaluations as possible and not kid ourselves. I mean, we don't have decontamination units. Our first responders aren't prepared. We have a nuclear plant in my district, which brings other issues to the fore. So I just think we have to be realistic in our assessments of costs and work together to make sure we get those dollars. We're all on the same team. We want to help you.
Can I just jump in for 1 minute, because I wanted to make the point that preparedness really is a process, and what you're describing is a very large set of responsibilities for a local health jurisdiction, and we have made the first investment and are about to make the next investment. But this is a sustainable process, and we've got to count on the fact that we have a lot of work to do as we go forward. We're starting with a public health system that in many places was broken. And so it does take this kind of investment.
But what I'm saying is, and it's not just smallpox, and I respect your huge responsibilities. I just came from a hearing on BioShield. Now, we're talking 5 years down the line, where unfortunately there is real information that there could be a serious threat now. So if a community is expected to respond to the threats, and add smallpox to that tremendous responsibility, you have oversight over so much of the response mechanisms in our communities, and we have to help you and make sure that you have the money that is needed. And I know our chairman is sensitive to this, and we're all part of the same team, but we can't kid ourselves. I mean, my district is north of Westchester County, but in talking to the people from New York City, they're spending $5 million a day on keeping the community safe. Their bill was $900 million. The president's talking about money for Homeland Security minus the Coast Guard of about $2 billion. It's not going to get there. So let's work together to make sure we have the resources to help you, help our local communities, help all of us. Thank you. I guess I'll hold the other questions.
I submit for the record, I have a couple, and then we'll go back to my colleagues here. I've been asked to speak back home to a symposium captioned, "When Teens Weigh Their Self-Esteem." There will be 5 experts to discuss symptoms and treatments for eating disorders. And there'll be present coaches, teachers, parents, and so on. Is this a new identifiable topic, eating disorders among teens?
It's not a completely new topic, but it is a growing problem. Eating disorders generally are thought of as anorexia or bulimia, where there's a desire to be excessively thin and unhealthy behaviors follow that, although some would say that eating disorders now have been expanded to include the same unhealthy patterns that lead to obesity. What I think is at the root cause of this is something that Mrs. Northup brought up earlier, and that is that we're confusing body image and cosmetics with health. And what we really need to do is concentrate on what is a healthy body, not what is a cosmetically perfect or ideal cosmopolitan body, if you will. And for some teenagers, both boys and girls, this is a real problem and a growing issue in schools.
Well, it would seem the topic would open itself up for education on good eating practices. Would you agree that?
I do agree. I think the message of healthy eating is a really critical component of that. But when your self-esteem is really involved in your thinness, the message about food is hard to take in and respond to.
Couple of questions. One is, how do you and how does CDC and NIH relate on research? You've talked about research, and they do research. Do you discuss what direction you're going to take to avoid overlap between the two agencies in research projects?
Well, Dr. Zerhouni is just marvelous, and we have sat down and had very specific discussions about what needs to be a seamless pipeline of research, from the very molecular level to intervention trials, and then more in the CDC bailiwick of the public health part of that. How do we take that science and put it into intervention programs and evaluate them? And we have a number of very successful examples. For example, one of the studies that identified the fact that you really can prevent diabetes through lifestyle changes, that was an NIH study, but CDC collaborated on it, and now CDC is taking that information and learning through our public health research how to put it in different communities and disseminate it and get it to be a component of the community programs. We have similar programs in cancer survivorship. We have a program in arthritis. We have programs in occupational health that are working that way. So our genomics program, in many of these categories of public health concern, we have a very solid and I think extremely synergistic relationship with NIH. And I will just say also that Secretary Thompson convened a retreat of the leadership of the Department of Health and Human Services a few months ago to identify the department-wide priorities. Dr. Zerhouni led the proceedings of that strategy development, and again we were able to identify and agree on, yes, this is a priority for us and this is how we'll go forward as we try to focus on the priority health problems and the research needs collaboratively.
Well, I've had an idea that we ought to make the healthcare delivery system more seamless, and that would be CDC, state health departments, local health departments. Are we making any progress? Is there a high degree of communications among these various levels that deal with health, the health of American people?
I love the concept of seamlessness. We have made a lot of progress, and I think the dollars in the public health preparedness grant program have really helped us a lot. But again, I feel like we were starting with a public health system, particularly at the local level and in some states, that just had for decades been very neglected. And so in order to really build that seamless connectivity that you're talking about, it's going to take a little more time. And we have 90% of our local health departments now connected to us for health alerting. That's a profound achievement, but we want 100%. So we have to keep working on it.
You have a hotline now, don't you? So that anyone 24 hours a day can call?
Yes, we do. We have one hotline for the public. The public hotline is not yet 24 hours a day. We also have a clinician hotline. So, for example, during the SARS problem, if a physician has a patient and they're not sure how to isolate them or what to do with that individual, they can call the CDC clinician hotline. We can get them that information on the spot.
Incidentally, I'm going to put this chart on my website.
Great.
I think this is a good education tool for the American public.
Great. We'll make that available to you in a format so you can.
Second round. Dr. Weldon.
Thank you, Mr. Chairman. And actually, I want to talk about the obesity thing a little bit, and also the lifestyle issue. I practiced medicine for 15 years before I was elected to Congress, and I still see patients about once a month, so I saw this all firsthand. I was in the trenches, as you said earlier. I'm curious, the obesity problem, is that evenly distributed across all racial, ethnic, and income groups? I've heard it said, but I don't know if I've actually seen the data that the obesity problem is actually a much bigger problem in low-income groups. Is that true, or is pretty much a universally distributed problem?
It is a universally distributed problem now, but there are still disparities, and there are racial and ethnic groups that are at higher risk for obesity and for the more severe forms of morbid obesity. But there's also geographic variation that we can't completely explain. For example, there are states that have, on a regional basis, much higher rates of obesity than neighboring states, and we can't account for it just by the composition of the population or the socioeconomic class. So there are a lot of factors that play into this, but the bottom line is it is one of the components of health disparities that we need to address and close the gap on.
Also, is there any relationship between the relative cost of food as a percentage of family income in the United States and the increasing rate of obesity? Specifically, has there been any decline there? As I understand it, if you go to some third world countries, 80% of family income is devoted to food, 50% of family income is devoted to food. And I don't know what the figure is in the United States, but I know it's in the low to mid-teens, I believe. And has there been any change in that to correlate with this increased incidence of obesity? In other words, are food costs going down? And is that playing a role in more people becoming obese?
That is one of the hypotheses that does fit into this. Food prices as a proportion of family income are declining. Food portions are going up. If you go out to eat over the last decade, there's been a progressive increase in the size of basically anything that you would order in a restaurant.
Hey, you're not kidding. My wife and I split the entree most of the time when we go to a restaurant. It boggles my mind what the average restaurant puts in front of you. I used to be able to eat like that when I was 16, but now...
Use your pedometer.
Well, actually, I exercise pretty regularly, Doctor. Thank you for your promotion.
I won't charge you for the advice.
I want to commend you. You haven't had to turn to your experts a lot. We get a lot of people that come before this committee, and we ask them questions, and they start turning to the people to their right and left. So you really have an excellent command of the issues. Is anybody looking at these electronic cards that most of the states have gone to with the food stamp program? it would seem to me that you could do some very interesting research with that in terms of looking at, what people are buying and possibly correlating that with information on obesity and in terms of educational initiatives. I know that's not in your bailiwick, that's in the Department of Agriculture. Is that correct? But it would seem that the CDC could possibly take advantage of that in terms of a research tool.
That's very interesting. I'm not aware that we've done that, but I will follow up on it. We do know that some foods, like certain starch-laden foods, are among the cheapest things that you can buy in the store. And so families that are finding it difficult to feed their children will reach for those very inexpensive food items that often have the least nutritional value but have the highest fill your stomach up value, instead of buying things that would fit more into the food pyramid, like fruits and vegetables and so forth, that are relatively more expensive. So the economics of food pricing does play an important role in food choices in families where dollars are the rate limiting determinant of the choice. We do know that from some very specific research studies. But I think the idea of looking at other information about how different populations of people choose food is a good one. We'll check it out.
My time is up. I just want to close off with one important point. I read your testimony, and you have a very important point. The overarching goals of this collective focus, I'm quoting from your testimony, are to ensure that we as an agency do the following. And you have a series of bullets, and number one is practice evidence-based science grounded in sound peer-review research. I'd really like to see that standard applied to the AIDS prevention program in particular. It's $1 billion a year. We haven't had that for the last 8 years, 10 years. We need to really focus on that so that we're really doing a better job of reducing the incidence of this disease in this country. I used to take care of AIDS patients, and I was able to see firsthand the devastation of this disease, and I don't think we've done a very good job in this arena, and I'd really like to work with you on this issue.
Thank you.
Mrs. DeLauro.
Thank you very much, Mr. Chairman, and thank you, Dr. Gerberding. I want to, just one point, I would recommend to my colleagues a good book to read about the, it's actually a cultural change in the United States. It's a book called Fast Food Nation by Eric Schlosser. It really, when you're looking at Wendy's, Hardee's, McDonald's, Taco Bell, Subway, and I mentioned Subway is the national headquarters is in my district. But when you go down that whole list and you look at the low cost of food and a number of families looking at that, but everyone is dealing with fast food. And as you take a look at what they're eating in the fast food establishments, there's an association there as well with health, obesity, and some of the things we've been discussing. I don't think that this comes from just one group or one ethnic a group making a determination or not to make a determination on what's been the best lifestyle. Our entire culture has shifted, and I think that that is really what we need to try to deal with, rather than trying to isolate just different groups and their lifestyles. Let me move to Wise Woman. I'm going to put in the record information on the security at CDC, as well as some ovarian cancer questions and the shortage in lab space. There was a recent article in the Washington Post about that. But let me get to Wise Woman, a program that I really do think has made a difference. And I'm looking at your book on the chronic illnesses, and this is the Michigan program on Wise Woman. Heart disease, stroke, cancer, most prevalent diseases, costly health problems, uninsured women, particularly vulnerable because they're less likely than their insured counterparts to receive the kind of screening that they need for breast cancer, high blood pressure, cholesterol. So 1995, CDC initiated the Wise Woman program. It provides heart disease, stroke preventive services to participants in the National Breast and Cervical Cancer Early Detection Program, which is another CDC effort. What we do there is providing breast and cervical cancer screenings to low-income, uninsured women ages 40 to 64, screens women for risk factors for heart disease, #1 killer, and for stroke, #3 killer for women, and provides lifestyle, counseling, education as appropriate. This program is now in 11 states. Really 2 questions. I was pleased that the breast and cervical cancer account received a 5.7% increase. That's about $11.4 million. I was confused to see that the Wise Woman program sees a decrease of about 20%. And the questions are, can you explain why breast and cervical cancer, that line would see an increase, Wise Woman would not? Will the grantees lose their funding? And I think you know this, but Congressman Leach and I have a piece of legislation which would allow CDC to expand the Wise Woman program in all 50 states, give grantees the flexibility to provide preventive health services for diabetes, osteoporosis, as well as cardiovascular disease. Can we count on you for your support, Dr. Gerberding, in this piece of legislation?
Well, we are very enthusiastic about Wise Woman, and it is a program that works. And I think we're going to be looking very hard at what makes it work, because we want to be able to adapt that to the the steps to a healthier U.S. program. You mentioned Michigan, and in the state of Michigan, we have seen as the screening for these conditions goes up, the rate of death from breast cancer is coming down, and in the subset of people you're dealing with, we're also seeing improvements in the cardiovascular risk profile. So this program works, and I think we intend to continue the program. We are definitely not planning any program cutbacks or reduction in sites, and in fact, we have 15 demonstration projects now going in Wise Woman. So it's not just 11 states, there are a total of 15 projects. I think we also one of these projects is in a tribal health group as well. So we're trying to.
Can you explain we increased the breast and cervical cancer line, but why not increase the Wise Woman?
I'm going to have to look into that.
Can you check on that
I will
for
check
me?
on that.
And I'm going to assume you're going to help Congressman Leach and myself and give us your support in this legislation. Am I assuming correctly?
We'll do our best.
That's a secret.
And if you could get to me, if you don't have that information now, what it would cost to have the Wise Woman program in every state. I just think that, I've said this over and over again, no matter what the program is, and I know because CDC has a number of programs that are or pilots or the demonstration program in a certain number of states, but the fact is that your geography should not be the determinant of your health outcomes. And when we do know something like breast and cervical cancer detection program, the Wise Woman, where we've added on the cardiovascular area, and all the pieces that people have been talking about is lifestyle counseling and all these efforts. In Michigan, you have a program that even partners with local groups here, with the League of Women Voters, to encourage women to deal with physical education and the stores to get equipment and shoes, the appropriate running shoes to do this. These programs work, and we should be spending our time figuring out how we take these across the country. And I know that's where your ideas are. But anyway, thank you very much. Thank you, Mr. Chairman. Sorry to go over.
Mrs. Gerberding, I have another meeting to go to, so I've asked Mr. Peterson to close out, but I want to, before I leave, say thank you. It's been a very instructive hearing this morning. I think the work that you're doing there is vitally important to the American public. I wish that the public knew more about what you do, and I would urge you to take advantage of media possibilities and allow people to understand the value of the Center for Disease Control in their lives, and how you sometimes can be helpful with the hotline. But as I said it earlier, it is a well-kept secret. among the general public, and yet it's an enormously important resource. Question, how many people do you have overseas? Because when I talk about it, I say, well, you have outposts throughout the world. Look on the watch to prevent things from getting here. You must have quite a few people that are stationed.
We have a couple hundred people on detail in various parts of the world, including at the World Health Organization in Geneva, but in some of the more remote areas as well. For example, we have a very, very important field station in Kenya that does a great deal of field work in malaria prevention, in HIV prevention, in diarrheal disease prevention, and so forth. And we also have a similar emerging infections program in Thailand where we have a critical mass of staff. But we support laboratories around the world. We support epidemiology and investigation capacity around the world. And we're there. We're out there.
You're always on the lookout, if I would understand it correctly, for things that might get here and try to, if at all possible, avoid having them start out here. SARS would probably be an example, but it's here to an extent. Mad cow disease, which apparently never really took hold in the United States. And I think it's an important role that CDC plays as sort of the watchdog for all of us.
I think our scientists in the infectious disease world in particular would appreciate that you understand that we are the sentinels for global health, and we put a great deal of effort and energy into detecting emerging health events, whether they're biological or otherwise. But there are still weak links in the system. When SARS evolved in Asia, in the Guangdong province of China, which is now where we believe it probably evolved, we didn't have anybody there. We weren't part of that initial epidemic. But when it occurred in Hong Kong, we already had CDC scientists available because we'd been watching for the avian flu. Now we have scientists in Beijing, we have scientists in Hong Kong, in Hanoi, in Taiwan. So our people are there really supporting this investigation.
Well, in this day and age, we hear a lot about biological warfare or threats to the United States. It's part of why we're in Iraq, ostensibly. It seems to me that CDC has got to be on the front lines in preparing and being ready to deal with that type of thing if it were to happen.
Well, we are, I think, a very important part of Homeland Security and Homeland Defense, and I'm very proud of what CDC has accomplished over the last couple of years in terms of the evolution and taking this new responsibility in stride. But it is really being built on what has always been our core capacity, to identify health events when they emerge and investigate them, respond to them, and support the laboratory aspects of that. So it's a new job, but it's being built on some of the familiar skills that we've had for a long time, and we are doing our best. We really appreciate the support that you personally and the committee has given us. We are very lucky to have the support that we've had.
The nation's very lucky to have the Center for Disease Control. Dr. Isold, the House physician, said I should give you his regards.
Thank you.
You worked with him on the anthrax issues.
Absolutely. Thank you.
Mr. Peterson.
Thank you, Doctor. Do you have any data from our schools that would tell you what schools are doing phys ed, what schools are doing healthy lunches, what's going on? Do you have any link with the school systems in America?
We do have linkages with the school system. We have a number of states that are supporting school-based health programs. I can tell you that right now about a third of schools in this country have comprehensive physical education programs, but most schools do not. And we have information in some school districts about the content of the school food program. We mainly work with the schools and groups like the parent-teacher organization or the local school boards to put in intervention and evaluation programs, school district by school district by school district, but most of what actually is done in the school district is determined by the local people there and their own preferences about what they value and what they want in their school. But we do have information, and if you would like as much detail as we have, we'd be happy to get it for you.
I just wondered if you established an email system, whether you did it through the states to the schools, but we're a monthly suggestion from CDC of how to healthy lifestyles, physical education, adequate physical education activity, healthy salad bars in the lunchrooms. You know, salad bars are not an expensive thing. Every school should have one as part of their lunch program. I mean, you know, giving people the right options, but they're not. And I have a school that I wanted to share with you in Titusville, who was one of the leaders in the country to a comprehensive physical education program, and it was just one of the teachers who went out and researched it and found out one out west someplace and copied it. But both the middle school and the high school have complete gyms. The young people go multiple times. I don't know if it's daily. I think it might be daily for their physical education class. They wear monitors. They are taught from 8th grade on up that they need to get the heart rate up for so many minutes, and at the end of each period, they report how many minutes their heart rate was up, and it's all put in the computer. I mean, usually people learn about the importance of their heart rate when they've had their first open heart surgery. Yeah. The average American. And here we have young people learning, and they don't have to do some silly game they don't like. They can skip rope, they can ride the bike, they can do the Stairmaster, they can do the treadmill, they can go out and play basketball in the gym, they can run around the school building and come back in. It's all about getting their heart rate up, putting the measurement in the computer at the end of the class. And I think it's a program that, once you have the equipment, is not that costly. You know.
I'd love to see if that program is linked up to our verb campaign, which is to get a verb and to get your heart rate up, and the verb cannot be eat. But I think we're thinking along the same lines, and CDC is looking for creative ideas that are working to
I'll
link
share
into this.
all their stuff with you, but they're very proud of it. They go all over the country. I mean, he's called out all the time to explain their program to other schools. But
great.
But that's the sort of thing that happened there because of an individual. Another issue, do you have any plan of action? See, I agree with several speakers here today. I think the lady from Kentucky, Ms. Northup, mentioned it, but rural America is less health conscious than suburban urban America. In my view, obesity is greater in rural America. I mean, I have a very large rural district, but obesity and health awareness. Recently, I heard, and I get this information and share it, but there's a study going on at Penn State that they've been commissioned to do. Why in Appalachia is cervical cancer still very high when in the country it's dropped measurably? Why is breast cancer still very high in Appalachia when it's been dropping in the country? Why is colon cancer at a high rate in Appalachia? And during their first report, which I was able to view, the slide showed there was one county in my district's Appalachia, part of Appalachia. There was one white county which was low rate, and the speaker mentioned that it in the early data showed that maybe because of the proficiency or having clinics. This rural county is less than 20,000 in population, but it's a big county. Has one hospital that serves 2 counties, but they have 12 clinics where every community has access to health care. In much of my rural district, you have one hospital in a large county or sometimes serving 2 counties. People are a long ways from health care. There are not local offices. And doctors' offices are open, daytime hours, not evenings, So if the first phase of this study shows that having clinics available, rural clinics, and it might be a model that you might want to look at, but it is a study being done at Penn State on why cancer is still so prevalent in Appalachia.
Thank you. We will look forward to learning about that.
Yes.
Thank you.
I made a couple suggestions to you today. I'm going to make one more. I don't know what you're allowed to do. I know you serve other masters. I think you personally have the skills to be a spokesman on America. I think you have the skills to be on TV. And I hope somewhere down the road, because you have so much, your department has so much to tell, that I hope in the evening primetime news that I see you and maybe other people in your department that have good public skills that are a part of every health story, telling the American people why, how, and where we are with health and the importance of healthy choices. So I mean, I just think and I hope somewhere down the road the Surgeon General joins you. I mean, I don't think he's been a very public figure. I think that should be a public figure job, but that's another discussion for another day. But I would hope, and I've also been pushing the president's people. You know, the president may be the first president we've had in a long time that has some good health habits that the young people in America ought to be a little more exposed to. And I've been urging his people to allow him to be a little more public about his exercise habits and his, as his wife says, very regimented of how he treats his body and what he consumes and what he eats and the healthy lifestyle he's trying to live at this part of his life. And so I just think the American public need examples and need people speaking out, and I think you'd be a very good voice.
I really appreciate your vote of confidence.
Thank
you. Thank you.
This hearing is adjourned.
Thank you.
Hey. Thanks for letting us borrow that.